Welcome to session 6 of the APASL Liver Cancer Preceptorship Program, ALCAP program. I'm Dr. Shuichiro Shina from Tokyo, Japan. I am the president of APASL, Asian Pacific Association for the Study of the Liver. Today's topic is systemic treatment for advanced hepatocellular carcinoma. You will get new knowledge on the treatment of advanced HCC through this 1 hour and 30 minutes webinar, so please enjoy. I would also inform you that the 33rd annual meeting of APASL 2024 Kyoto, which will be held March 27th to 31st next year. The abstract submission is until October 31st. And the pre-registration is until December 31st. We would like to welcome all of you in Kyoto with cherry blossoms in full bloom. Thank you very much.
Good evening, good morning, good afternoon, everybody. I'm Simone Strasser. I'm a hepatologist from Royal Prince Alfred Hospital and the University of Sydney in Sydney, Australia. And I'm joined by my co-moderator, Professor Tawasek Tanwandi from Bangkok, Thailand. I would like to kick off the very first talk of this very exciting session that we're going to have on systemic treatment for advanced hepatocellular carcinoma. And it's my very great pleasure to introduce Professor Peter Galle, who's a hepatologist from the Department of Internal Medicine, University Medical Center Mainz in Mainz, Germany, who's going to lead us through a presentation on first-line systemic treatment for HCC in patients with preserved liver function. Thank you.
Dear Shiv, Sareen, dear moderators, dear colleagues and friends from India, thank you for the opportunity to present recent data on systemic therapy in hepatocellular carcinoma with a focus on first line. These are my potential conflicts of interest. When we talk about systemic therapy, this is the standard of care in advanced stage disease in BCLC stage C patients. This is a standard example. We have multinodular disease. We have a thrombus in the portal vein, and in arterial phase here, enhancement is shown, hallmark pattern of hepatocellular carcinoma and advanced stage disease. In this setting, the SHARP trial some 15 years ago was the first trial to demonstrate at that time, compared with placebo, an improved overall survival, roughly 3-month difference, hazard ratio convincing 0.69, similar hazard ratio for the confirmative Asia Pacific trial, although the absolute numbers were lower because patients were more advanced. This stimulus resulted in several phase 3 trials, but it took about 10 years until another TKI, lenvatinib, was able to demonstrate non-inferiority compared to sorafenib. So we had another option of a TKI in this setting. The side effect profile, the adverse events profile was distinct. There's more hypertension for lenvatinib, more hand, foot, skin reaction for sorafenib, but in the end it needs to be appreciated that tolerability was not that good. Liver patients with liver cirrhosis suffer receiving TKI therapy. There was a lot of hope then with the emerging immunotherapeutic interventions that this is for an inflammatory tumor such as hepatocellular carcinoma also beneficial. However, the monotherapeutic intervention, particularly with nivolumab and pembrolizumab, unfortunately only resulted in individual responses, but not as statistically meaningful differences compared to sorafenib. So the hope was then that combinations of immune oncological agents would be better than monotherapy, and the first immune oncological intervention in combination was bevacizumab and atezolizumab to enter the market. Beva is not just normalizing tumor vasculature, has a complex impact on the immune environment, decreasing the activity of immunosuppressive cells and promoting dendritic cell maturation and antigen presentation. This combination was investigated in the IMbrave150 trial in a 2-to-1 fashion, randomized against sorafenib and going for co-primary endpoints, overall survival and progression-free survival. We were all very impressed when those data were getting public, and in the initial analysis, absolute data were not yet available. In the updated analysis, which I'm showing here, we saw a improved overall survival by about half a year. Quite significant, good hazard ratio 0.66. And in a similar way, also progression-free survival 6.9 versus 4.3 month, hazard ratio 0.65. Very convincing, very statistically and clinically meaningful data. What added to those outcome data in Kaplan-Meiers were the objective responses. 30% objective response unseen so far, including 8% complete response. And if responses were reached, they were quite durable. In terms of safety, numerically, there was not a big difference when you take all grade AEs, grade 3, 4 AEs, or even grade 5 AEs, quite comparable between the two arms. However, there were relevant differences. First of all, bevacizumab contributes to a certain risk of bleeding. Fortunately, it's mostly epistaxis, so minor bleeds, but there are some esophageal vessel bleedings which need to be taken into account and requires scoping of these patients for varices before getting started on therapy. On the other hand, it's quite obvious that the side effect profile is different in terms of its relevance to the patients, to the quality of life, to the well-being. Diarrhea and hand-foot skin reaction for sorafenib is clinically meaningful, whereas the most prominent side effects, hypertension and proteinuria in atezo-beva treated patients, is actually not making a big difference in everyday performance. This is probably the relevant background for the comparative quality of life analysis, where a median deterioration in the quality of life at a meaningful level was taking almost a year in atezo-bev treated patients, whereas as short as 3.6 months for sorafenib treated patients. So quality of life is better maintained and efficacy is there. That of course stimulated other clinical trials concerning new combinations, either combinations of IOs plus IOs, IOs with other VEGF inhibitors, and of course IOs together with multityrosine kinase inhibitors. A tyrosine kinase inhibitor, cabozantinib, was tested in combination with atezolizumab and bevacizumab. It went for a dual primary endpoint, and one was hit, that was PFS, difference of 6.8 versus 4.2 with a good hazard ratio, but unfortunately no difference with respect to overall survival, and this combination is no longer pursued. A positive trial was the Himalaya trial, and this is an IO-only trial with an interesting approach. It starts with a single dose of CTLA-4 inhibition, tremelimumab, followed by continuous dosing of the combo tremi and durva, and it was compared both against durvalumab and sorafenib. This is the primary analysis showing that it takes quite a while, 6 months, and this is different to Atezo-Bev, where separation of the curves occurs much earlier. Here it takes about 6 months, but then curves separate and stay separated. Here, after 3 years of observation, 10% difference, and that is confirmed, and these data are quite mature in the overall survival analysis after 4 years, demonstrating that even after 4 years, 1 out of 4 patients is still alive, 25% overall survival, which is a significant achievement. There is ongoing discussion whether certain subgroups benefit less or more, and this is particularly concerning NASH patients. I'm not taking this aspect into my discussion today. It's, I believe, fair to say that in all trials, probably all subgroups do benefit from therapy. What is relevant that is the fact of hemorrhage compared to the IMPRE-450 data. Here, in this setting of the Himalaya trial, we saw no esophageal vessel bleed. However, it needs to be appreciated that this trial excluded patients with portal vein thrombosis, a patient subgroup with a significant bleeding risk, not part of this trial. A similar trial compared to Himalaya is Nivo-Ipi, again PD-1 and CTLA-4, but here ipilimumab is given 4 times, and will be very interesting to see whether this different approach compared to sorafenib or lenvatinib in this setting is making a difference, also particularly with respect to the adverse event profile, which to a larger extent is attributed to ipilimumab. A disappointing trial was the LEAP-002 trial, lenvatinib plus pembrolizumab compared to lenvatinib plus placebo. Initial early phase data very promising, high expectation, and then we saw the outcome 21 months. That is very long for the combo, but unfortunately lenvatinib was showing a super performance in this setting, and the difference, the absolute difference, is statistically not meaningful. Similar data for PFS, no big difference here, and this combination unfortunately is not further pursued, although those who had this combination in the hand saw impressive results. A similar approach is coming from the combination of camrelizumab and rivoceranib compared to sorafenib. So again, a PD-1 inhibitor and TKI. And the data actually are quite impressive for PFS, a very nice hazard ratio of 0.52. And in the respect to absolute numbers of overall survival with a median overall survival of 22.1 months, the best data we have seen so far. In the West, because this trial was fueled to a large extent by patients from the East, and we know that region and etiology makes a difference. Typically, they are used as stratification factors. So we're a bit uncertain what this combination, what the role of this combination in the Western world is, but it's certainly an impressive positive trial. All those data have really shaped the recommendations, the guidelines significantly. It was very easy 20 years, a bit more than 20 years ago, where I was in the palliative setting in advanced stage disease, the hope for new agents. Now we have the new agents, and we now have a complex armamentarium to be offered in advanced stage disease. But as you see, this is shifting to intermediate stage, and I would like to just give some information on earlier stages, as this will play a role in general. We have seen an interesting trial where the combination of atezolizumab and bevacizumab was used in an adjuvant setting in patients with high risk for recurrence. And indeed, there was a reduced recurrence rate for patients receiving atezo-bev. A bit disappointing that the curves after about 2 years are getting together again. So the long-term benefit is still questionable. Here we hope for longer-term observation. And there are several trials in intermediate stage disease added to TACE, or in a situation as the ABC-HCC trial where atezo-bev is compared with TACE. So there is indeed a lot going on also in intermediate stage disease. As my take-home message here, we have an important tumor. Immunotherapy is in place. We have 2 options currently and more to come. Unfortunately, we do not have biomarkers at this time to predict response, and we see a lot of trials going on in earlier stages. Thank you very much for your kind attention.
Thank you very much, Professor Galli, for that wonderful presentation. I think we'll come back to questions and discussion afterwards. Tawasek, is that right? During the panel discussion?
Simons, Professor Peter Galli, are you still available at the end of the lecture?
My full day is dedicated to APASL, so at your disposal.
Fantastic. Okay, so let's move to the second line treatment. I think it's my great honor and pleasure to introduce Professor Stephen Lam Chan from Chinese University of Hong Kong. He is a clinical oncologist, and he's going to cover on second-line systemic treatment for the patient with disease progression or intolerant with the first systemic treatment. I think he's going to update us the very update from the ALCAP. Professor Chan, please.
Thank you, Chairman. Let me share my screen. Could you see my slide?
Yes.
Okay. So first of all, I would like to thank the APASL for inviting me to speak on, which I think is going to be an interesting and very important topic for our HCC patient, which is a second-line systemic therapy. So these are my disclosures. So in the next 20 minutes, I will walk you through these 3 areas. First of all, I will talk about the situation and the reason why we are talking about second-line systemic therapy nowadays. And the second part, I will walk you through some of the data on the choices of the second-line systemic therapy after different situations. And finally, I will use few slides to highlight the impact and also the future directions of the second-line systemic therapy. Let's talk about the why first. I think in the audience and also in our panel, we all know that in the past, we only have one systemic therapy. And therefore, when you fail this first-line systemic therapy, you basically have no choice or evidence-based choice. Each clinician is only able to use their best educated treatment or based on experience to give some subsequent line of therapy for the patient. So of course, we know nowadays we have many different first-line choice, as already highlighted by Professor Galli. And also, we know there have been some evidence-based second-line treatment, backed up by phase 3 clinical trial or some by phase 2 robust clinical trials. But in our real-world situation or in our daily clinical practices, how is the situation of the use of second-line therapy? We may take a look of these table, which one hand in one column show you the year of the recruitment. And on your right-hand side, you can see the proportion of the patient receiving the subsequent line of therapy. And then you can see a trend that back to the old days of reflex study, around 1/3 of the patients will receive the subsequent line therapy. But then you can see after 2016, when you are talking about the clinical trials on the first-line immunotherapy, the percentage of patients receiving subsequent therapy is up to more than 40%, perhaps with the exception of the Iron Brave 150 study. So this somehow highlights the fact that the subsequent, or particularly the second-line therapy, is getting more common, at least in the clinical trial setting. Then you may ask me, how about the real-world situation? This is a large database study just published a few days ago in the European Journal of Cancer. There are more than 40 authors in this paper, which suggests it's a really robust study by capturing data in the USA, Europe, and also the Asia. I will not go into too much details at this moment, but you can see amongst the 1,000 and over 300 patients, in the real-world setting, in fact, even higher than the clinical trial, nearly close to 50% patients who have PD actually receive a second-line therapy. Again, this highlights the importance or the popular use of the second-line therapy. And then a few days ago, we have the ALCAP meeting. Our group has also presented a database on the use of second-line therapy. And then you can see, actually, if you talk about the first-line IO treatment, afterwards, more than 50% of patients also receive subsequent systemic therapy. And I will not be very surprised, all these data I talk about data back to 2021. In my experience, and I'm sure we can share later, now there's probably up to 60% of our patients may also have a chance to receive a second line or even third line of the treatment. Then I move to the choices. We know there have been theoretically three scenarios in the first line setting. Theoretically, sorafenib, and also lenvatinib, and also post-IO treatment. In this group of panel and audience, I will not bore you by going through all the phase 3 clinical trials because we are all familiar or by the phase 2 trial on the EP level. So I will skip this part, but if you want, we can talk about the data later. I will talk about more the post-lenvatinib or the post-immunotherapy. We know there have been no phase 3 clinical trials designed to address the subsequent treatment after the lenvatinib, but we can learn something from the data. This is actually very important data, in my opinion. It's a real-world data in Asia conducted by our Japanese colleague. At that time, there's still no immunotherapy, so approved for second or third line use. So basically, you can see they basically use more TKI or the antibody after the failure with the first line lenvatinib. So what we observe is first, you can see, despite the relatively small sample size, you can have a hint that if you try to use the sorafenib after the lenvatinib, the outcome may not be as good as those patients receive more potent TKI such as regorafenib. And this is not surprising because we all know that in terms of the efficacy and also the spectrum of the receptors coverage, the sorafenib is relatively a weaker drug than lenvatinib, and therefore you won't be surprised when you use a weaker drug after failing lenvatinib, the outcome may not be as good. It seems that the use of the TKI, more potent TKI like Rego after lenvatinib is associated with some benefit. Another important observation is actually back to this database probably from the 2019 to 2020, already 40% of patients are suitable for subsequent line therapy after first line and also after the second line, resulting in around 16% patients suitable for third line treatment. Again, I won't be surprised nowadays we have a high percentage patients receiving 3 lines of therapy. And also, as mentioned, maybe the choice of TKI may matter in terms of second line setting after the prior treatment with lenvatinib. Then how about other real-world data? This is also a retrospective multi-center study from our European colleague. At that time, perhaps they can have some off-label use or maybe on-label use of a PD-1. But still, you can see probably because of reimbursement and cost issue, a lot of patients use sorafenib, but there's also a lot of other treatment, as you can see in this table. But the key point is you can see for those patients who were able to receive the subsequent treatment, there's a much better survival compared to those patients who either are not fit for or have no chance to receive the subsequent line of therapy. And again, this highlights the importance and the prognostic impact of enabling our patient to receive a second line or third line of the treatment. But then I go back to the first database that I just talked about, which was published a few days ago. And this is a very big database. They have more than 900 patients receiving lenvatinib. Around 1/2 patients could not receive second-line therapy. Another 1/2 receive different second-line treatment. Interestingly, you can see apart from sorafenib, of course, they also have some patients on immunotherapy. Quite a lot of patients received the TACE as a salvage or second-line treatment after the failure with lenvatinib. I think this somehow highlight the real-world practice that we are no longer restricting systemic therapy for our patients with advanced disease. If patients somehow have previous response and they have some progression in the liver, maybe they also may, a lot of MDT or clinician may choose the TACE for treatment of patients. But perhaps I go back to the sequence of the systemic therapy. Then you could see that, again, you can see if the patient receive S, which is a sorafenib, versus those patients receive immunotherapy as a second line, there's a clear separation of the curve, suggesting that perhaps we should use the immunotherapy better in those patients who have received the first line lenvatinib. But of course, nowadays we know more interesting data will be the subsequent line of therapy after the prior treatment with immunotherapy. This is one of the database, real-world data done by our group and also Korean group and also the Singapore group. In summary, we look at those patients who have a prior treatment with atezolizumab and bevacizumab. And once they have progression, then we look at those patients who were able to receive the second-line multi-kinase inhibitor. Again, probably because of reimbursement issue, more patients received sorafenib, but still a number of patients received lenvatinib, and one patient actually from Hong Kong received the cabozantinib. And I think the take-home message is even in the second-line setting, of course, this is a bit selected population. Perhaps they have good performance status, reasonable liver function, but you can see just the OS counting from the first stage of receiving multi-kinase inhibitor is actually more than 1 year. In fact, sometimes in old days we talk about there's no room for clinical trial in second-line setting. But if you talk about you have median OS of longer than 1 year, actually there's still a lot of room for us to develop therapy in this indication. At this moment, for patients who have been prior treatment with IO, mainly atezolizumab and bevacizumab or other IO therapy, there are a number of ongoing clinical trials. I think one of the most important is the IMbrave 251, which is looking at the continuation of the PD-1 or PD-L1 plus by changing the partner to the TKI versus the TKI. This will guide us or give evidence whether we could continue the IO beyond disease progression. But we also have a number of other single-arm studies, usually investigator-initiated study. We know that just last year, December in the ESMO Asia, with a readout of this study. This study actually led by conducted within our Asia, with the collaboration between our center and also Korean colleagues, 2 Korean colleagues. Basically use a phase 2 trial looking at the cabozantinib in those patients post-immunotherapy treatment. These were the inclusion criteria. We allow maximally 2 lines of prior therapy, so it's studying either second line or third line treatment. All patients will be treated with cabozantinib 60 milligrams once daily, and the primary endpoint is progression-free survival, and the secondary endpoint were quite standard with the AE and also overall response and overall survival. So these were the baseline characteristics. I just like to highlight 2 points. First of all, we actually spent relatively short time to recruit the patient, only around 1.5 years. Sometimes we may think, oh, it may not be easy to conduct second-line trials. Actually, nowadays we know the patient tend to be fitter with better liver function. And also, not surprisingly, around more than 70% patient had chronic hepatitis B, 60% 1 line, and 40% with 2 lines. These were the main outcomes. In terms of median progression-free survivals, it was 4.1 months. And the 6-month PFS rate was 32.5%. Interestingly, when you look at the median overall survival, For those patients who just received second-line therapy only, the median OS was 14.3 months, which is exactly the same what we observed with our retrospective database in Asia. If the patient received either 2 or 3 lines, 1 or 2 lines prior therapy, i.e. second line or third line setting of carbo after IO use, the median OS was 9.9 months. Another interesting finding is the grade 3 or above AE is quite low, only 6%. We believe this is because the side effects profile of cabozantinib is quite familiar with within Asia, because we have used it after failure of Sarafi. Therefore, with flexible dose reduction and also management of AE such as handful skin reaction, the AE rate actually quite low in this population. Then I will finish my last part, which is about the impact and the future second-line therapy. This is just a table summarizing some of the old studies on the second-line therapy. Perhaps we don't need to go to the details of this clinical trial. I just want to highlight the observation that you can see with time from 2009 to 2017, there's been gradual improvement of the overall survival, not only in the treatment arm, but also in the placebo arm. But then when you look at the median progression-free survival, actually there's been no significant improvement of the PFS across the time, which means that the improvement of the OS perhaps may not be due to or partially due to the improvement of the efficacy of the systemic therapy, but also may be due to some other factors. Maybe the improvement in hepatic function, maybe the overall status of patients is better, maybe we use the systemic therapy early, or maybe due to the more subsequent line of therapy. We can discuss later, but this is the real-world observation. We have been seeing better OS in this setting. Another point I would like to highlight is nowadays we always talk about drug accessibility, because we have a lot of clinical trials telling us that first-line IO is good, and then you use the TKI or some other treatment as a second-line treatment. But when we talk about the treatment sequence, maybe we observe something different. On the left-hand side is the real-world data done by our group, and then when you look at the sequence, TKI, TKI-IO, or IO first line, TKI second line, or IO-IO, maybe exception of the IO-IO, or maybe, maybe you can see then a bit trend of the better median OS, but when we try to look at the statistical analysis, actually there's not much difference between different sequences. Maybe the tail, the IO-IO may have a better tail. In fact, if you look at the European data just presented recently, for those patients received atezolizumab bevacizumab as the first line versus those patients receiving the lenvatinib as the first line, interestingly, you can see there's not much difference in the overall survival. My feeling is maybe the subsequent line therapy may also contribute a lot of the pattern that we observed. In fact, this is also data by our group. We try to analyze those patients with a first-line IO use versus those patients with a later IO use. In fact, there's not too much difference. So the implication is, of course, from the phase 3 trial, we should use IO combination like the STRIDE or the atezolizumab or the pembrolizumab plus the viroceralib if approved in the first line. But in those countries, especially in Asia, where the cost is an issue or drug accessibility issue, maybe we can reserve the IO to a later to be used in the second or third line, while we can use some cheaper or affordable drug in the beginning, maybe a practical solution to those countries with limited resources. I think we may also discuss. In fact, nowadays I don't think this type of sequence have been studied thoroughly by the sponsored clinical trial. Last but not least, I just want to highlight in terms of prognostic factor after first-line treatment, hepatic function is important. If we need to maintain the patient in good liver function, in my opinion, this highlights the importance of MDT to ensure our patient have proper and optimal management of Hep B and Hep C. And also, if the patient has some cirrhotic complication, perhaps we should engage our hepatologist colleague to manage those cirrhotic complications. And finally, I still believe that when we should have a judicial use of TACE to minimize the liver injury to those patients before we subject them to the systemic therapy. So, ladies and gentlemen, this is my concluding slide today. I think it's fair to argue that standardized therapy is relatively standard nowadays in the practice of HCC. And to enable subsequent therapy, preservation of hepatic function is the key. And the following lymphatic treatment, I think based on all these data, the optimal treatment appears to be IO. And for post-IO treatment, TKI seems a reasonable alternative. Just like colorectal cancer, we need to expose them to drugs of different mechanisms. But I agree, more real-world studies on the sequence, not only the first line, second line therapy, is important and will be required to address more questions. So I would like to acknowledge all of my team members who generated all of the data, and also thank for the grants that have supported our study. So thank you very much for your attention.
Thank you so much, Professor Chan, for very excellent coverage on more recent data, especially the data from Asia Pacific regions, as well as from the western part of the world. I think the treatment is still evolving. So any of you who have any questions, you can have the Q&A chat box at the bottom of the screen. So any question from our panelists?
Yes, Professor Tawandi, this is George.
Yes, please, Professor Lau, please.
Yes, I think Stephen made a very good job there, and also Peter. In fact, well, I would like to throw a questions in the real world. Second-line therapies. When would you consider this? I mean, for patients with advanced hepatocellular carcinoma, and when would you use a second line? I mean, after the first line, how will you define? There are patients who are very nervous with the alpha-fetoprotein, and there are also inconsistency of the imaging techniques and the size measurements using the RECIST criteria and so on. How long would you tolerate, especially in the IO age? We have seen response even after disease progressions. So how would you like to address these questions in the real world? Maybe Peter or Stephen want to make a comment?
Yeah, I mean, the question of progression pattern comes into place. It certainly makes a big difference whether there's a minor increase in a liver lesion or whether there's a new appearance of an extrahepatic lesion. In the latter case, I would rather early switch. In the first case, I would probably take my time and wait a bit longer, because all these trials to a large extent allowed treatment beyond progression, and that apparently also in the IMbrave 150 trial was beneficial. So pattern of progression, I think, needs to be taken into consideration when you make that decision. Stephen, do you agree?
Yeah, I agree. I think George raised a point that theoretically, according to oncology principle, patient with PD, according to whatever criteria, either RECIST or modified RECIST, they should be changed to second-line therapy. But we know liver cancer patients are a bit different, in my opinion. Sometimes they may have a little bit progressive disease, but then they are doing fine. Doctors, I want to continue the treatment. They will like this. And they may be usually they tolerate the drug very well. And also, I sometimes a situation I agree, some alpha-fetoprotein elevation. But then when you keep the imaging, you don't see that much of progressive disease. This highlights the fact that when we make the decision to switch, there are multiple factors that we should consider. I will ask a question: am my patients going to benefit from the drug either clinically or from the laboratory or radiological point of view? I have a lot of patients on lenvatinib, and they have some minor PD, but they're doing very fine. And also there's some drug access issue because immunotherapy in second line in Hong Kong is still not reimbursable. I have a lot of experiences, just continue the lenvatinib, or sometimes adjust the dose a bit escalation, and they can do fine with another 4, 5, 6 months, or sometimes more than that. So I agree how to define the change of the drug is really a real world issue that had not been addressed adequately by the clinical trials.
In fact, I think that we need some standardizations to understand the data, because then otherwise it will be very variable and we'll never be able to have evidence-based answer to our patients, even if we are only talking about hepatitis B related hepatocellular carcinomas. So I hope that the group Asia Pacific regions could, with the help of people like Peter, comes into some of the nomenclatures so we are going to use, and we can really look at the data. So you have presented a few very good papers, but then when I look at those papers, it's very difficult for me to decipher and then to convince myself what is the message when we are not consistent in a sense in the real world. It's very difficult to be consistent. There are multiple factors, as you pointed out. So I'm not sure about the values of these data sometimes in our patients. And having said that, in places like Hong Kong, and we are close to China, and there are lots of PD-1 available across the border. So it's getting more and more complicated, especially when you see patients with hepatocellular carcinomas and how to manage them. It's with IOs and so on. So I think as a responsible clinicians to face these cases with hepatocellular carcinoma, we need to have some ideas or standards that we can follow. Unfortunately, we don't have a very good biomarkers. That will be easy. But then what is the thoughts behind, and how are we going to move forward? Otherwise, we will be seeing a lot of data and analysis, log-rank analysis, survival analysis. But then how are we going to understand these data? So that's the questions I want to have the discussions with the other panels members and the audience.
George, I think you make very good points. I mean, in the clinical trials, it was all based on imaging-based progression, obviously, and well-defined. But in the real world, clinicians do what clinicians do and will continue to do, even if we have guidelines. So I think it's going to be very challenging, and it's very difficult when you're watching a patient with an alpha-fetoprotein that's progressively going up, even though you can't see radiologic progression. You assume they've got progressive disease in that context, and I think clinicians then do tend to change. I agree.
We have over the years continuously assessed our patients, and it was always very clear that the more lines of therapy you apply, the better the outcome. But what was absolutely unclear was whether patients are just fit to receive therapy and survive longer, or whether this is really the impact of therapy. And I think this is an open question which is extremely hard to answer.
Can I just raise another question and to go really the opposite direction, and that's about downstaging with systemic therapies, and get comments particularly from Professor Galley and Professor Chan and the other panelists about the potential of systemic therapies. Now we're seeing such good responses, including CRs, to downstage to resection, to liver transplantation, and to potentially curative therapies and approaches, and how the data is looking in that area.
Well, we used to move in the BCLC system from left to right, and in the end, the patient died. And now we get more and more reports on therapeutic conversion, where you're seeing an unexpectedly good result, you move back to resection or to transplantation. And that has been particularly reported for Atezo-Bev treated patients. And now with the IMbrave 050 data, adjuvant, of course, neoadjuvant is the question. And I constantly get pushed from my surgical colleagues that we should do something about neoadjuvant treatment. There is extremely high expectation. In individual cases, it already works, but we have no thorough understanding whom to offer neoadjuvant treatment with a decent chance to really get into resection or transplantation.
Simon, you raised a good point. Actually, in ALCAP, there have been just a presentation of the PRIME study, which I think by the UK group looking at the use of ipi/nivo as a neoadjuvant treatment in patients with resectable tumors. And the PCR rate or the major pathological response is very high, talk about nearly 40%. And those patients have very good survival outcome. And all those translational studies show those patients have increase in the immune surrogate in the peripheral blood and also in the resectable samples. So I think I agree with Peter. there's a push for the neoadjuvant setting. Another scenario you can develop is more for the patient with unresectable tumor. And then you aim to use the IO or the systemic therapy to downstage. I was told not to use the convert in ALCAP because convert has a strict definition. But somehow downstage or change them to resectable. I think this is another scenario. Personally, I think we should push more to the neoadjuvant because we can have a PCR rate as a surrogate. We can have an easier readout, and also the antigen load. I believe in those settings is also easier than the adjuvant setting. But I think you're right. Basically, my feeling is that immunotherapy can be used in earlier, post-operative, intermediate, and also advanced setting in the future. This is a reality.
It, of course, brings new questions, such as rejection rates in transplanted patients after neoadjuvant therapy. At ASCO this year, there was an interesting protocol presented, neoadjuvant treatment with IO. And the endpoint of the trial was in fact not response, but the rejection rate after transplantation, whether that goes dramatically up or not. 10% was considered to be acceptable, 50% not. That was the difference which they expected. So new trials needed, yeah.
So at the moment, Peter, in the transplant space, what should be the minimum interval between the last dose of IO and a liver transplant, do you think?
This is not defined. We have basically two observations. First one, even after a period of pre-treatment with IO, which is a very long period ago, you see a higher rejection rate and they can be fatal. But on the other hand, there are protocols demonstrating that neoadjuvant IO treatment is feasible and patients are able to receive a transplant. I think if you pay attention, and of course that needs to be studied in clinical trials, but if you need pay attention and you are very aware of rejection periods, then it's doable. But the precise protocol or the timing is I think not known. Yeah. It's not just the IO and rejections, also bevacizumab and healing and bleeding. So it needs all to be better defined than it's today.
Thank you. Okay. Professor Tanwandi, I think we should move across to the grand rounds and then we'll come back for further discussion.
Yes, I think if so just to remind the audience that if you have any questions, you just type on the Q&A chat box, and then we're gonna come back with the Q&A at the end of the grand round.
Okay, thank you for that excellent discussion, but we will move across now to the grand rounds, and it's my very great pleasure to introduce Dr. Subrat Kumar Acharya, who's a Professor Emeritus and Pro-Vice Chancellor, Division of Gastroenterology and Hepatology, Kalinga Institute of Medical Sciences in Bhubaneswar, India. Well, I invite you to share your presentation with us, Dr. Acharya. Thank you.
Thank you very much. And thank you, Dr. Sareen and APASL for asking me to do this grand round. And just give me a minute to share my slides to start the case discussion.
That looks good.
Yeah, my slides are visible. Now, I have a patient here who is a patient of liver cancer. And this patient is a 56 years man. And somewhere in March 2021, when the COVID pandemic was going on, he presented to us with a pain abdomen, and which was intermittent, moderate to severe for 3 months, for which he needed a medical attention. He used to consume alcohol fairly frequently for the last 15 years. And since the pain started, he was abstinent. but he doesn't give any features of any bleeds or altered sensorium or any history of abdominal distension or edema indicating any form of decompensation or jaundice. Well, if you trace his history back, if you see, he had a splenectomy in 1991, during which he had blood transfusion. And then, about 10 years, he developed a type 2 diabetes mellitus, for which he was started treatment. And somewhere beginning of the 2021, he had mild icterus. I didn't get the records, but at that time, his old record has showed that somebody has done anti-HCV, and his anti-HCV was positive. Hepatitis B surface antigen was not negative. But remember, he was a diabetic too. And in March 2021, he presented to us at AIMS with pain. He was essentially have a normal hemodynamic status. So there was no features of any jaundice, cyanosis, or any ascites or edema. He had a weight, he was weighing 65 kgs with a BMI of 26 kgs. There was no classical peripheral stigmata of chronic liver disease. Liver was palpable 2 centimeters, which is quite far, but there was no spleen or ascites. The rest of the systems were essentially normal. And then this was his investigations. And you can see easily the investigations that basically his lab parameters are essentially normal except RAGE transaminases. And albumin was also normal. Renal functions were also normal. But he was C positive, and hepatitis C was almost 1.3 million per milliliter. And he was a diabetic. That you can see. And we did a upper GI endoscopy. We didn't find any remarkable or esophageal varices or gastric varices, but his liver stiffness was high. This was above the cirrhotic level. And so we thought he has a compensated liver disease. And in a routine practice, we just do a alpha-fetoprotein in such patients who had hepatitis C and had a history of transfusion way back in 1991. And lo and behold, the alpha-beta-protein levels are quite high. There were 6,000. And in the ultrasonography, we couldn't find any space-occupying lesion very clearly, but we found some lymph nodes in the peripetal and peripancreatic, which was sizable, about 2 centimeters. Now, obviously, it was obligatory to go do a triple-page MR scan. And you can see in various stages, there is a large tumor, which was occupying almost segment 7 and segment 6. And interestingly, you find a large lymph node in the periportal area, which you can see quite big at about almost 3 centimeter size. So he had a classical LIRAD5 HCC with a lymph node, which is extrahepatic, but his portal veins were patent. And we thought we'll also, since alpha-fetoproteins were very high and we know certain of the biological aggressiveness of the tumor, not only predict response, also predict recurrence rate as well as survival. And since his alpha-fetoproteins were high, we wanted to check at the degree of aggressiveness and did a PET scan. And the lymph node was lighting up and the tumor was also lighting up. So obviously, it is a biological aggressive tumor. And you will never need a biopsy in this patients and classical LR5. So we didn't do a biopsy, right? So the diagnosis was, since there is an extrahepatic involvement of a large lymph node, we gave a BCLC staging C. He was perfectly okay, except that he was not doing strenuous physical exercise. His performance status is 1. He was alpha-fetoprotein and PET was avid, indicating bile aggressive. Now, we thought it's not only SCV, it is also alcohol. And diabetes might be aggravating the risk. He is CTPA 5 and MELD was 12, no varices. He was on anti-diabetic drug. So then, obviously, what is the stage of SCV? Next questions were, what is the stage of SCV? And can you further categorize the liver function A5? We know that albumin, bilirubin albumin ratio dividing, even child says cirrhotic to grade 1, grade 2, grade 3 based on the logistic. regression they have developed, the response rate and overall survival as well as recurrent-free survival were different. So in this particular patient, obviously, Dr. Gale has shown this. This will be classified as advanced SCC and stage C, and the recommendation was systemic treatment. But well, in India, we classically, every patient cannot follow systemic treatment, and recently we have modified this because all portal vein thrombosis in the BCLC have been included in the advanced stage C. But if you see portal vein thrombosis in eastern sector has been divided, and more aggressive treatment to particularly smaller vein occlusion like BP1, BP2, and BP3 can be done by local radiotherapy or transarterial radioembolization or SBRT, downstage them, resect them, transplant them, which were just people were discussing depending upon individual cases. So I think in India, we modified. And if you see the BCLC stage, it doesn't include the radioembolization or radiotherapy at all. In this group stages of patients, where indeed a local treatment can reduce the tumor and subsequently they can be transplanted. In many of these patients who are not suggested to be transplanted, indeed they can be transplanted, and many such patients are being done in India. And there's a large report from Medanta Hospital of 50 cases. Even with portal vein thrombosis, they cleared the portal vein thrombosis and transplanted them successfully. Now, I told you all about ALBI because I've just collected the data and I'm showing a literature how overall survival, 5-year overall survival, ALBI differs between the grade 1, grade 2, and grade 3, irrespective of the type of studies. And liver has to be fit for any form of treatment. And different form of treatments are being given depending upon the stage of the disease. But the categorization liver to further ALBI helps tremendously. So in our patients, it was BCLC C2. As I told, we classify C2 as extrahepatic lymph node involvement and vessel involvement as C1 because we can tackle the C1. Well, C2 is a little different and difficult to tackle. That's why we subdivided BCLC C into C1 and C2. And we also calculated the ALBI score, thinking what treatment should he will respond. If it is ALBI1, he should go hell all the way up to treat him and give him the benefit because he has extrahepatic manifestation. But he was ALBI2 and he has also biologically aggressive tumor and probably etiology was well. It's a good liver function. So he had good liver. He had good performance status. There is no cardiopulmonary renal risk for combination of any form of immunotherapy. There is no portal hypertension, and obviously he can tolerate therapy because he's good. At that time, our question was, what should you do? Now, can you do resection in this patient? But well, you understand that resection will be probably not nice because of the extrahepatic spread and that load is quite large, about 3 centimeters. And liver transplant for the same reason is not a candidate. Ablation for more than 5 centimeter tumor is question is difficult. It was subcapsular tumor. And also there was extrahepatic spread for which you should have to combine therapy. Transarterial chemoembolization could have been done, but again, the extrahepatic spread limited us. And transarterial radioembolization, selective intraarterial radiation therapy can be done, but again, you need a combination. And simple stereotactic body radiotherapy for the liver tumor doesn't work. We don't know the results of extrahepatic nodes and the results of SBRT and what is the risk. It is near the pancreas, near the portal vein, near other vessels. So we're not sure about that. So systemic therapy can be given and recommended by all guidelines. We could have combined systemic therapy with local therapy for the tumor, but will it be better? That was the question, or it will be more toxic to the liver, or it will be more expensive. It looks rational that attack both intrahepatic tumor and combined with a TKI for the extrahepatic lesions. but we didn't do it actually. Because we couldn't find very solid evidence that combining TAS and TKI actually made any difference in outcome, as I put down in some of this study, barring Dr. Kudo's tactic trial. That is the sole trial where he has done continuously transarterial chemoembolization and has given also continuously the TKIs, right? And there he has seen when you combined and continued with the transarterial chemoembolization, the overall survival is markedly more. But we are not very convinced. And also it has been seen that lenvatinib per se is probably better than transarterial chemoembolization and therapy. So we are not very happy because of extra hepatic load and the evidence of combining both the therapies, giving him a benefit in terms of cost and side effect were clinically weighed, and therefore we thought we will not combine it. And second thing, whether TAR could have been given, and but if you see in comparison to systemic therapy, this is just a meta-analysis which was published, and you'll be surprised to see that TAR comparison to systemic therapy has almost similar outcomes. So we thought we will, and also recent network meta-analysis showed that Atezolizumab, which has been already done and many studies has been published, has the superiority, and lenvatinib was not very bad, quite good. And there are a large number of patients in this network analysis. And it was also shown in this network analysis that the progression-free survival between lenva and Atezo was not very greatly different. And we know that the immune checkpoint inhibitor and targeted therapy are given for essentially advanced stage and treatment stage migration or untreatable progression, but should we have good liver and good functional status. And that is very well known. And so what we started actually, we started with therapy for Hep C with directly acting antiviral standard, and we successfully had SDR also later on. And then we started him on lenva in May 2021 because it was COVID and you need actually Atezolizumab under supervision, and it was a little expensive. And we know that even though Atezolizumab has been suggested as the first line drug followed by lenva, we thought lenva is maybe better. The reasons were here given. In India, this is the cost between Atezolizumab and lenva, a quite marked difference, and needed a supervised therapy. Because of this reason, we first started him with lenva, and also we thought that lenva works better in the patients with alpha-beta protein. In the REFLECT trial in subgroup analysis, this has been very clearly shown. This is better, and the progression-free survival is also better than sorafenib. So we thought lenva may be a good candidate, and just now the LEAP trial has been discussed, and you have seen that in the LEAP trial, one thing marked that the median survival of lenvatinib was about 19 months, as Dr. Gale pointed out. So, and if you see the subsequent follow-up study of IMREF 150, also showed the median survival of about 19 months, even though they are not head-to-head comparison. We thought lenva will not be very bad drug. It looks cheaper. It is the COVID time. There is no supervised therapy. We cannot monitor him well. So let him take lenva at home. And he came back to, we started lenva somewhere in April, May, and he came back to us in July and see the tumor is same. And he has started developing diarrhea, he has nausea, intermittent vomiting, he feels fatigue with the drug. We don't know whether it's drug or the tumor, but he complained that he cannot tolerate this drug. So we thought we can discontinue. We discussed the patient. Patient was the employee of the institute, and therapy was supported by the institute. And we thought that since now there is a grade 1 evidence of using immune checkpoint inhibitors in such patients, in advanced patients, we started atezolizumab in standard dose, and we decided the duration will continue the dose treatment till he develops significant side effect or progression of disease while on immunotherapy. By now, he has received 11 sessions of this combination of therapy every 3 weeks. The starting date was 3rd August 2021, and it has been stopped in March 2022. And obviously, the response were evaluated according to M-RECIST criteria in these patients, which is very much well known. And you see, this is while on treatment. This is in October. We started in July. So July, August, about 3 months, the tumor is almost gone in 3 months' time in these patients. And if you see, this is January, that is about 6 months, say, the tumor is gone, but he is still on therapy. He is not off therapy. And if you see, this is in 1 minute. And this is after 1 year, and in February we of the treatment, and it still is fine. And if you see the alpha-beta-protein, how it dropped in July when we switched, it was about same. But after that, once we started adizumab, it also started dropping. And if you see the real world, this was almost a complete response, all of you will agree. And if you see in the real world scenario, the response rate is not very high, about at best 2 to 13%. And we have at AIMS treated about 19 or 20 patients and have a good response rate. I was surprised. And they are doing well with this therapy. And this is the real world. And you can see the results in all these combinations are obviously better than the oral sorafenib, barring the last trial by Finn, where pembrolizumab, and there is a lead trial where it was not shown to be effective, and it was shown the pembrolizumab was shown to be as effective. It is anti-PD-1 as effective as Lenva, and there is no benefit. Now, question was, what we will do to this patient after this complete response? Should he continue? Should he stop? Should he observe? Will he recur? What is the recurrence rate? It has been only since last 4 years, the atezolizumab has been cleared by the FDA and has been available in the market. And the follow-up is very small. And despite that, the chances of recurrence rate exist, and in some of the studies I was seeing 1 year recurrence can occur after about complete response, about 10 to 15%, or even of some one case series is given 20%. Now, this is what I was found very interesting, that even after the question was being discussed with Dr. Kale and others, they can be transplanted. What should be the observation period after complete response, or fitting in downstaging, fitting into Milan's or UCSF criteria? What should be the duration of response, 3 months or 6 months for a recurrence of disease or a progressive disease before you take up a call for transplant? And post-transplant following immunotherapy, is there an increased chance of rejection? And all those rejections will be difficult to manage. Here is a case series where there are 5 patients who have been subjected to transplant, and at post-nivolumab, of course, but at variable duration period, that is, they have operated at different period of time, about starting from 5 weeks to 10 days to 4 months, 6 months. And you will see 4 out of 5 are alive at the end of 1 year, and only 2 deceased. So, which was an untreatable advanced cancer, and they are showing results that can be cured. And this is another series of cases, about 12 cases. And if you see that rejection rate are practically not happening in such cases. However, they are early days. So, ladies and gentlemen, I will say from this case, and as has been presented earlier, the advanced hepatocellular cancer, and we divide them into C1 if the vein is obstructed or vascular invasion is there, or C2 when there is this extrahepatic spread, particularly the node. They can be both treated with oncological remission. I saw the case, and we had a complete response rate out of 19 cases, about in 15%. Or you can have stable disease with improved overall survival. And seems to be the Atezolizumab and now Duvalu and Tremelimumab has come in and cleared by Himalaya, following Himalaya trials. These combinations are better than even local regional therapy. What I showed you some data, and including internal radiotherapy. And particularly this is so if you have extrahepatic spread, as we had. And in these cases, combining even the radiotherapy with ablative therapy would not have probably helped. I don't know, the experts there are more experienced people. And therefore, sequential therapy, as it was discussed, whether it is possible, and it seems it's possible from various studies from Dr. Chan's presentation. And lastly, I posed this question, whether PCI can be post-ICI liver transplant is possible even in such advanced SCC, aiming for a cure. Thank you very much.
Thank you very much, Professor Ajaya, for this excellent and impressive response for this case. I think this already complement to the previous 2 talks from Professor Gallis and Professor Chan. Any questions or comments from our panelists and also our audience?
Congratulations. This was a very comprehensive discussion, and I like the solution of favoring systemic therapy. So again, congratulations, very well presented.
Professor Chan,
thank you, sir. It was a pleasure listening to you as well. But I thought there are many questions. This patient had responded very well. That's what I thought we will present it. But there will be questions like that. Suppose you have a partial response, and the extrahepatic lymph node is gone. Will you transplant him? Will you give him a second-line therapy? You will use a transarterial radiation embolization? You will give a SBRT, or you combine? What should be the best in him? And his liver is good. He is good. He's walking.
It's a very difficult question. The patient starts with negative prognostic aspects. Alpha-fetoprotein above 1000 is not a good candidate for transplantation. Right. But then you have the complete response. And not only this, you have it maintained even after quitting therapy for a decent period of time. So that would give me a very good feeling for transplanting that patient. But this is a, let's say, gut feeling, not very academic, I'm afraid.
Stephen, you have any?
Yeah, sorry.
Yes, Stephen, go ahead.
I just want to supplement. Dr. Akaria has presented a very good case, and we just discussed this also in ALCAP a few days ago. There's actually an ongoing randomized study in Shanghai, in China. They are asking the same question. For those patients with very good response, either extrahepatically or intrahepatically, from immunotherapy, they randomize them to either surgery or just observation. So obviously, surgery is to resect those, theoretically could resect those residual tumor, and you can assess the PCR rate. But on the other hand, we have a lot of experience that, like your case, keep CR or disease-free for a long time, which we know probably representing the tail. So this study will help us address whether we need surgery for this type of patient. So I agree, you raise a very good point, and always in our MDT, we do not have the evidence to tell us whether surgery, transplant, or the observation. And my experience is usually elderly, they tend to have more observation, while for younger patients, we tend to resect them or transplant patients.
But that is the experience we present downstaging, because despite downstaging, you observe for 6 months to see whether the disease is progressing, because then the recurrence-free survival post-transplant is influenced by those observation periods. That information is well known. But if you see the immunotherapy, immunocheckpoint inhibitors data, and if you see the complete response rate can go up to 15-20%, what I'm seeing gradually with first and second line therapy. And that means every 5th person with advanced SCC has the chance of having complete response rate. And some of them will definitely recur, knowing that, because there will be cirrhotic, there will be mother focus of mutation. SCC is a multi-step mutation process. So they can recur. Now, will they be better? And now, since you are doing it under APSL, will it be better to think and start a trial on a multiple center, wherever the trial is going on, to do transplant or to observe and retreat them when recurrence occurs?
I think they're all very good points. And I think this case really raises the issue of how important it is that these patients are managed through an MDT, where you've got all the expertise in the room, and that you keep bringing the patient back to the MDT to say, should we be doing something new, something different for this patient, whether it's resection, transplant, downstaging to local regional therapy. But it's really critical that these patients are managed in that forum where all the expertise is present.
Can I make a comment, ma'am?
Yes, Dr. Sharma.
Yes, please.
Yeah, very congratulations, sir, for the comprehensive discussion. So my point is that in the patient with BCLC extrahepatic metastasis, one can easily go for radiation therapy to the primary site as well as the lymph node metastasis, followed by systemic therapy. And there are papers like one paper is from Matoba et al., which is published in 2020 only. And they have also suggested that if the loco-regional therapy is being followed by systemic therapy, either in the form of lenvatinib or atezolizumab, bevacizumab, there is very high chances of local control and increase in overall survival.
I understand that. I understand that these are case series and sequential series. But unless you have taking complete response as your major outcome, or a measure and try a sample size, calculate a sample size, and then in one arm you give local radiotherapy or SBRT or THER, which followed by systemic therapy. At what interval we don't know, whether combined or subsequently. What will be the adverse events? What will be the cost? What will be the response? Those are unanswered questions. So those gaps will be there when you have such case series, and there will be some patients who will respond depending upon the biology of the tumor and their response. That we know. Even lenvatinib causes response. Even many other previously sorafenib had also caused response. So it is a very heterogeneous disease with a heterogeneous background, with a heterogeneous outcome. So, but well, yes, I agree that there should be effort to combine, because there are various forms of treatment now available, and they can be combined in various sequences, and but planning clearly based on initial evidence. So
yes, we need some randomized trial.
Whether that is possible or not.
Yes, we need some randomized trial where sequential therapy can be randomized into sequential therapy versus systemic therapy alone.
How difficult to do randomized trial in liver cancer patients, and how to actually homogenize them. Okay, fine with BCLCC, but within BCLCC,
so the point is, we can take yeah, we can take BCLC patient, especially with extrahepatic metastasis, and then we can randomize. Also, like in this patient, the LB score is very good with a -2.9. And what we have found that the further LB2 can be further classified as LB2A and 2B. So those towards LB1, they will do better with systemic therapy as well. Similarly, in this patient also.
Possible. That is good for us. It is helps. Obviously, it is good.
Thank you, sir.
I would like to raise another point, and I noticed this patient had active hepatitis C at the time that you diagnosed the HCC. Maybe some thoughts about, should we always just treat the hepatitis C as soon as we diagnose it, or is there some optimal timing in terms of patients and their treatment for their HCC? What are your thoughts, Dr. Acharya?
Yeah, you should continue and see the SBR, because when you give certain therapy and there is a liver cell necrosis, the Hep C is completely not eradicated. Hep C can go up and in fact affect the liver. This has been documented in patients undergoing transarterial chemoembolization with hepatitis C virus infection, where post-TAS hepatitis C virus load goes up and one can have deterioration of liver disease, not only because of TAS, but because of hepatitis C virus. So hepatitis C virus must be treated. And this normally in this patient, we didn't follow a standard recommendation of a 12 weeks therapy and 12 weeks. Right. We continued their therapy completely almost 8 months. And that was a clinical decision. We'll continue this therapy. Right. Until we stopped the immunotherapy, we continued. I didn't discuss about that.
I think Simon asked the question that is very interesting for the audience, though, because at the beginnings of the AA treatment, I think there was some thought about the resize of the Hep C in the hepatocellular carcinoma cell line, and the response rate in the patient with active HCC going to be lower in the patient after the cures of hepatocellular carcinoma. But I think with the more potent DAA, I think that may be possible. And also in these particular cases where the systemic treatment is not a curative, though, and then we need a treatment along with the treatment with hepatocellular carcinoma, I think.
Yeah, I would agree. Dr. Galley, you agree that we just treat from the get-go?
Yeah, we had this observation in 2016 coming from Barcelona, danger signal, but it was very clear after several further trials that this was coming from the inherently high risk of this subgroup investigated and not as a result of DAA treatment. I think that is a story which can be concluded, and if we take out the inflammatory process, that's certainly helpful both for immediate response and also for subsequent recurrence.
Any other questions or comments from the panel?
We solved it all.
I think we have.
So, can I?
Yes, please.
So what should be the gap in between the starting of anti-hepatitis C drugs and starting of immunotherapy? Means like in this patient, we had started with lenvatinib. Patient has already taken a long. There's a gap between starting of hepatitis C drugs and starting of atezolizumab, bevacizumab. So what should be the appropriate time?
We started right away lenva as well as Sofos Belpatasa right away in the month of April, May beginning. So we right away started the drug, both drugs, lenva as well as Sofos and Belpatasa.
So gap between immunotherapy and anti-hepatitis C drugs.
Yeah, this should be no
problem. No, we didn't do that, because if you give immunotherapy, the virus load may go up, right? And it has been seen in some patients of treatment with liver cancer as well as with tear. So we didn't stop the therapy. We in our minds, because the hard data was not there, and we are using immunotherapy, it should control it down. But you just don't know. So we continued. These are safe drugs, so we continued it, and lo and behold, the patient tolerated it well and the drugs well, and we saw the results.
Okay.
Thank you. I think Professor Masawa is here. Professor Omada? Okay. So, okay. So
I think
that
that brings us to, yeah, sorry, Dr. Chowdhury. Yeah, I think that brings us to the end of the discussion and time for the vote of thanks and the closure. Thank you.
Thank you.
So I think this is the 6th we have done it, and maybe 1 second Saturday, Tuesday, it is going on the program. Oh, now Professor Masawa has joined. Professor Omada, please, a few words.
Sorry, whom you are asking?
Professor Omada, you are mute.
Professor asking Professor Omata.
Yeah. Professor Amato, have you got any words you'd like to say?
Well, Acharya, I'm here. I was late. Sorry about because of my business in the hospital. I just came in, so I just listened to the last part, so I couldn't make a comment. Sorry about. Sorry,
No, sir, it is nice to see you after a long period of time.
I just catch up. Sorry.
Oh, I think both of you are here, Professor Sareen and Professor Omada. Just say kind words before we close the session, though.
Sorry.
Yeah. Sorry, I missed most of it. Also, I was dragged out. But I want to thank on behalf of APASL all the legends who have participated, and both myself and Masawa are very grateful for making this important. And I'm sure you will all know about Dr. Yuno's conference, which is being done, and also Dr. Ashok, who is doing a meeting on the International Liver Cancer meeting. So we invite you for both of these, the meeting in India and Japan. And we want to thank everyone for making a presentation. Very good.
All right. Andy, Dr. Gail, Stephen Chang. All right.
Thank you.
Good night.
Thank you, everybody.
All right.
Thank you.
Thank you very much.
Thank you very much.
Great meeting. Congratulations. Bye-bye.